Right. So next this evening, we're going to hear from the future Dr. Hannah Burleigh, who is a fantastic practitioner in acute care, and she's going to talk about trauma-informed care in the acute care setting. Welcome, Hannah.
Thank you so much, Carrie. Hi, everyone. My name is Hannah Burleigh, and the title of my research project this evening is The Effectiveness of Education on Trauma-Informed Care to Acute Care Occupational Therapists. Just a little bit about me. I'm currently an acute care occupational therapist, and I'm currently in the post-professional occupational therapy doctorate program here at Elizabethtown College. I received both of my I don't know what they're called, Carrie, I have the strategic leadership one and the trauma informed care. I guess they're certificates for
There's
the
graduate certificates. Yep.
Yes, for the post-professional doctorate program. And I decided I wanted to use both of them to lead a training module for other therapists in acute care to use as far as trauma-informed care goes. So in today's presentation, we're going to review the acute care setting and what that looks like, and then trauma's relationship with acute care. We'll review the concept of trauma-informed care and related topics, just because I wanted to have everyone have a basic understanding of trauma and trauma-informed care and ways that they can better understand the purpose of this project and the terms that I use throughout. And then we'll go into the methods, the results, and the final takeaways of my project as well. Just some acknowledgements here for Dr. Carrie Hampel of the OT department and Dr. Elizabeth Coyle, who taught me all about trauma-informed care. I just wanted to thank them both for guiding me in the right direction during this project. And then this is just a trigger warning for anyone that can find topics related to trauma as sensitive or triggering for them. So feel free to exit this presentation or take care if needed. You can, do self-care after this presentation, just kind of do what you need to do. So first, I wanted to delve into trauma and acute care and how they're related. So the term traumatic stress was developed by the American Psychiatric Association approximately 40 years ago, and it's referred to as an emotional response to a terrible event, such as reactions include unpredictable emotions, flashbacks, strained relationships, and even physical symptoms like headaches or nausea. Overall, the hospitalization experience can have lasting impacts on some. However, others can have intense traumatic stress reactions, or the event that they experience can also be traumatic. So not only could hospitalization be traumatic, but also the possible event leading to their hospitalization. Context and environment also change here. So previous social roles are abandoned, and it can often also cause financial stress on the individual as well, or disrupt their career. It can cause an inability to cope and adjust. For example, the person's life is suddenly controlled by the hospital rather than, their own schedule. It can exacerbate their emotional reactions to situations. So OTs must be understanding and flexible, and understand that, the hospitalization experience can be stressful. Patients are basically taken away from their homes. They're required to go to many tests, which can be painful or stressful, and it can cause interrupted sleep as well. Overall, the research that I found, and from my own personal experience too, I found that the hospitalization and the hospital environment can be very overstimulating. So these are just three main areas of the body that can be impacted by trauma, which I found in the literature. So the physical body, the cognitive self, and then social and emotional well-being. So physical changes can occur because of trauma, including areas of the brain, such as the amygdala and the prefrontal cortex. Stress can cause a dysregulated response, which can cause a constant cortisol production. There's something that's called a positive versus tolerable versus toxic stress response. So in a positive stress response, that's a normal, developmental, healthy response to stress. Then you have the tolerable stress response, which is usually from severe, long-lasting stressors, such as the loss of a loved one. But typically these stressors are overcome by intervention. And then you have the toxic stress response, which is prolonged stress, such as abuse, neglect, mental illness, or violence. And this can disrupt the architecture of the brain and the organs. It can cause an increased risk for cognitive impairment, and it can also cause inappropriate responses to stress long-term. And then within cognition, OT talks a lot about executive functioning, which involves a collection of mental processes that assist a person in organizing, planning, problem solving, and paying attention to and remembering details. So it really affects their working memory, their mental flexibility. And when executive functioning is impaired, it can cause a decrease in adapting to change, task completion, memory storage and retrieval, and planning and prioritizing as well. And then within the social emotional self, we're talking about basically behavior here. So when we think of behavior, I want you to think of it as an iceberg, or Delahook's developmental iceberg. So at the above the water, what you can see is behavior. That's the behavior that you can see the person engaging in. And then below the iceberg, or below the water, what you can't see are all of those things that explain the behavior. So internal bodily processes, sensations, emotions, memory, thoughts, and ideas. So kind of the what is happening and then why it's happening. Another thing that's also discussed here is the polyvagal theory. So it describes 3 neurophysiological states of that a person can be in throughout either their hospitalization or just in your session. So you first have social engagement, which is green. So this is where someone can connect with others and learn new things, and they're in a calm state. You can have someone be in the red system. So this is where the systematic nervous system is activated. They have an increase in heart rate. They have trembling muscles. They're ready to kind of protect themselves. And they might not be able to really learn here because they're kind of in a fight or flight. And then you have the blue state, which causes freezing. So often this is a form of self-preservation, and the body will just kind of shut down. The patient might feel no pain. They might lose bodily awareness. They may have decreased thinking ability here as well. So just kind of going over what systems trauma can impact here. So now that we know that trauma impacts someone, how can we become more aware of this as OTs providing intervention? Basically through this concept called trauma-informed care. So applying trauma-informed care involves understanding trauma exposure and related symptoms. It involves using evidence-based practice and culturally sensitive assessment and treatment. It requires providing resources on the impact of trauma and related treatment, teaching resilience to our patients, ensuring collaboration between disciplines, and maintaining an environment for staff and patients alike to address trauma. So the Substance Abuse and Mental Health Services Administration, I used a lot of their resources. They provide some key assumptions and some guidelines. So we'll go over that just a little bit tonight. But the main ones I'm going to go over are realization, recognize, respond, and resist re-traumatization. Those are just some guidelines that you can follow when you're addressing trauma-informed care. So like I said, these are the 3 key assumptions that they mention. So within realization, we must realize that trauma has impacted the person and why. We also must teach resilience to these patients and the ability to cope with trauma. And then we must also realize that trauma occurs in all settings and can be addressed by all settings. So it's not just a behavioral health concern. It's not just to be addressed by like psychological services. It can also be addressed by all areas of the hospital, including OTs. The next one is recognize. So understanding what the signs and symptoms are, someone who has experienced trauma. Also understanding that trauma can impact all populations, regardless of sex, gender, things like that. So it can impact anyone. And then also here is, they also recommend having appropriate screening tools as well. And I think this is a big area where more research is needed, specifically in OT, because you don't see a lot of trauma-related OT screening tools. So potentially this is an area of further research here. And then the third one is respond. So being able to apply all the trauma-informed principles to your patient during your sessions. You also want to make sure as a health professional, you are educating yourself and also educating the patient on what trauma-informed care is. And not only within yourself, but they also recommended that there should be change at the organizational level as well. And organizations do have a responsibility to also include it within their rules and regulations as well. So not just only, you know, from individual to individual, but at organizations as well, or the organizational level. And then the final one here is the importance of resisting re-traumatization. So leadership is responsible for ensuring that the staff works in an environment that promotes fairness, trust, and transparency. So like I said, not only at the individual level, not making sure we're not re-traumatizing our patients, but also making sure that we have an environment that is not a toxic environment or a stressful environment for the patients as well. And then overall, just providing compassionate care to those patients who might be at risk for re-traumatization. Another thing that I found in my literature here was the connection between culture and trauma, and how understanding culture is very important, or having cultural competence. So we must actively resist stereotypes based on race, sexual orientation, age, gender, and geography, because we know that trauma does not discriminate. It happens to everyone. Therapists must have self-awareness and insight into their own experiences with trauma as well. So having some self-awareness, being able to care for yourself before you care for others is also important. For example, if people do not feel like they belong, it can also cause a negative stress response, or it can trigger them as well. So making sure that you allow your patients to express their thoughts, feelings, and concerns with you, that'll help you to build a more trusting relationship with them. And then also looking at each individual like they are their own unique person. So everyone has their own thoughts, ideas, and beliefs about certain situations, and we need to be able to respect that. So going into the methods of my study here. So this study used a pre-test, post-test design. So using this method, there's an observation before and after the research is implemented, which I'll go into. It helps to understand change that has occurred in participants due to the said intervention. As far as the subjects goes for this specific study, this project in general was approved by the Elizabethtown College IRB as exempt, and subjects were not considered a vulnerable population, and there was minimal risk involved to them. The participants were used via convenience and purposive sampling. So they were acute care occupational therapists at an urban hospital. They were English speaking, they were full-time employees, and they worked in acute care, and obviously they were willing to participate as well. So first, an email was sent to them with the content of the survey and appropriate links. The pre-test, which was available for 1 week, kind of discuss their confidence and their current thoughts on trauma-informed care. And then after the participants completed that, they were sent the educational module, which was the intervention that I had created. And that was a 2-week process. So they had 1 week to learn the educational module, and then they had 1 week to apply their knowledge in current practice. And then in the final week, they were given the post-test to kind of collect their thoughts and to reassess their current knowledge of trauma-informed care. So all the surveys were anonymous and password protected as well. And then as far as data collection goes, the pre and post tests were in a Likert scale format. So that way I could compare and contrast the different percentages. Descriptive statistics were used to describe therapist demographics, and frequency distributions were used to kind of assess the difference between the different Likert scales, which we'll kind of go into then. And then there was also, at the end of the post-test, there was an area for open-ended responses. So those were also analyzed for common themes at the end. As far as the creation of the actual educational module, so this was an educational module specifically created for acute care occupational therapists to use with trauma patients or any patient that had experienced a traumatic event. It was created using PowerPoint and Zoom, and I had used PowerPoint and then recorded myself educating everyone on the different topics that I had selected. The literature review was done using current trauma-informed care literature in all populations using scholarly databases provided by Elizabethtown College. And topics were created in conjunction with other trauma-informed care professionals at the college as well, just to determine that we were kind of covering all of our bases. As far as the main topics of the module, this included the main principles of trauma-informed care, the neurobiological, it's a hard one to say, impact of trauma, toxic stress reaction, positive stress, intolerable stress, the sensory implications, executive functioning, social and emotional impact of trauma, intergenerational trauma and epigenetics, and then common trauma-informed care practices and interventions for therapists as well. So now we'll kind of delve into the results here of the study. So as you can see here, most of the therapists had been practicing for between 0 to 5 years, and then they had experienced motor vehicle accident, abuse and neglect, fall, complex trauma, community violence, and medical trauma patients. That was kind of the main types of patients that they were dealing with. As far as this one goes here, I understand the concept of trauma-informed care. So you can see here that they agreed, and then by the post-test, they had reported that they had strongly agreed. So it had an increase here. I understand how to apply trauma-informed care during my sessions. You can see that most therapists here were neutral. So it could suggest possibly that they didn't feel super confident about trauma-informed care in the process. And then you can see again in the post-test how they felt that they could more appropriately apply these principles. This one here says, I understand how trauma impacts my patients. Typically, it seems like overall they knew basically what was going on. However, it seemed like they were a bit more confident after the post-test. I am able to describe trauma-informed care to others. So you can see here that they felt neutral or they disagreed with this at first. And then there's a big change here that they felt more comfortable describing what trauma-informed care was. And then in this one, I feel confident in treating patients using a trauma-informed approach. And you can see that compared to the post-test, they had an increase in confidence. And then this one here, I am aware of current treatments using a trauma-informed approach. You can see that they felt mostly neutral or they disagreed with the statement. And then that there was a big jump to the post-test. And you can see that they seem to be more aware of current intervention. This was also just some questions from the post-test then. So they 100% strongly agreed that the training was informative and useful. They thought that the training module provided appropriate and modern language. And they thought that they didn't really think that the training provided or required further development. And then overall, all participants rated the following educational module from 1 to 10, 10 being excellent. Okay, so I wanted to delve into first kind of the creation of the educational module. Because participants found it effective, I just wanted to kind of include, how I developed it and why I developed it a certain way. And it's just some common themes and areas of importance maybe for future OTs to include in similar training modules. So I used a lot of concepts as recommended by SAMHSA, which we reviewed earlier. So the importance of establishing safety, trustworthiness, peer support, collaboration, empowerment, and culture, especially the emphasis on culture and how that can impact anyone and everyone. And then also just reiterating the importance of recognizing trauma and the signs and how it can impact someone's physical, emotional, and cognitive self. And then also intervention strategies, including connection practices, sensory practices, and cortical development interventions and colleague connection practices as well. And then from the open-ended responses and from the other responses as well, I found kind of 3 common themes from those here. So these are the 3 participants that had filled out the that you see on the screen. They're the 3 participants that filled out and had their own comments. And then from these comments, I kind of developed my own themes from these. So the first theme I found was the perceived lack of education and training out there regarding trauma-informed care. Currently, there's no other training that exists for trauma-informed care for acute care occupational therapists. Trauma-informed care was only recently introduced within the last 5 years. And from what I found online, research is mainly regarding children. So there's also a need for adult-based intervention as well. There have been few studies that have attempted to define what trauma-informed care occupational therapy looks like. So that it is definitely something that needs to be further developed because research has found that there's a lack of a common definition of what trauma-informed care looks like for occupational therapists. And from the results in general, you can see that most participants reported they originally in the pretest felt unsure about related concepts and interventions regarding trauma-informed care before the training occurred. So that's just kind of further proof of that. The second theme I found here was the relevance of trauma-informed care to the acute care setting. So the hospitalization process can be stressful, and through research, it has proven to be a traumatic experience for most people. And trauma-informed care can help to enhance intervention for these types of patients. There's also a history of hospitalization having bodily integrity violations. So trauma-informed care can help to prevent this as well, having a more informed mindset of how to prevent that and resisting re-traumatization. And in general, there's a need for further research in this specific practice setting of acute care. And then the final theme here, the training was effective in general in informing, oh my gosh, I can't talk. The training was effective in informing practitioners about current interventions. So overall, participants found an increase in confidence, knowledge, and understanding when addressing trauma-informed care with patients. Trauma-informed care, the approach in general can allow for more meaningful outcomes as well as within intervention. It can increase patient-therapist relationship and trust as well. Trauma can impact all areas of life, including engagement in occupation, health, and overall well-being. So in general, occupational intervention that is trauma-informed seeks to reverse behavior patterns associated with experience of traumatic events and to lessen anxiety, disruptive behaviors, violence, and depression. So overall, we can help patients to kind of increase those healthy coping mechanisms. And then as far as the limitations of this study, it was a small sample size. So there were 8 participants in the pre-test and then 6 participants in the post-test. It was only one practice setting. So of course that can be limiting as well. And then just me as the researcher, my personal connection to participants, even though it was anonymous, they could have still felt like they, necessarily couldn't provide completely honest feedback. So that's also a limitation as well. And then just a conclusion, if you want to take anything away from this presentation, you can take away this quote from my capstone that I had used in my paper that I thought was important. So, occupational therapy is a compassionate, patient-centered profession. When combining the principles of trauma-informed care with the underlying foundation of OT practice, true trauma-informed occupational therapy intervention can occur, allowing clients to successfully participate in meaningful occupations. Thanks, everyone. I will now be taking questions at this time.
So if you're in the audience and you'd like to ask a question, you're welcome to just unmute yourself and ask, or you're welcome to tap that question into the chat bar, and I will be happy to moderate that as we go. You're getting some wonderful jobs. I'll agree with that. You did a nice job. Anybody have any questions?
I have a question for you, Hannah.
Sure.
First off, fantastic job. Very, very
Thank you.
interesting. I feel like this is such an important topic. You know that already. I don't have to say it. It just has such a big impact on OT right now, and it's such a big thing for us all to be paying attention to. My question is, you had a specific context area. I did too, not the same one, but I ran into some of the same kind of thought processes. But with the training that you had, do you feel like you would need to change a lot if you were to apply that to a different context? Or do you feel like it would generalize pretty well, or could be generalized pretty easily?
Yeah, I think definitely it could be generalizable very easily. I have a lot of experience in acute care and how the initial traumatic experience can impact someone of like the initial injury or illness. So I think that's how it would be a little bit different. Kind of, we get very acute patients and very emotional patients. So I think that's kind of how it would be different from other experiences. Like, for example, in pediatrics or older adults or things like that, the traumatic experience could have been, earlier in their life or something like that. But I think in general, the interventions that are provided can be used across, many contexts.
Great. That's awesome. Looking forward to seeing if you have those resources. That's awesome. Good job, Hannah.
Thanks.
Thank you.
So I have a question in the chat that I think is similar to one that I would ask, and that is, do you have plans for sharing your resources with other therapists?
Yes. So I currently have plans in January to go to at least 2 other hospitals to have this training for their therapists. I kind of wanted to open it up to not just OTs, but OTs and PTs as well. But my plan is to kind of spread it all over within, a reasonable driving distance for me. But my plan is to go to different hospitals in the area and then share this training with them as well after this project is done.
I can agree. I identify. And is this something that you have to do in person, or is this something that can be done hybrid, more of an online experience?
I was going to say I did it as an online experience to begin with, so it's certainly not required. However, personally, I do prefer to do it in person. I find that more like personally meaningful to me. However, there is an online option, and that was how it was done anyway. So
excellent. Other questions?
I have a question.
Go, Maddie.
Good job on your presentation, Hannah.
Thank you.
Do you think that every patient in the acute care hospital would benefit from like the trauma-informed care, or would you kind of base it off like evaluation if you would have more of that trauma-informed lens like when treating them?
I think that this can be appropriate for any patient. So like I had discussed, not only for patients that have experienced a traumatic event in their life, but as we know from the research, hospitalization in general can be a traumatic experience for many. Many are taken, out of their normal environment and their normal context. So I think even just for those patients, like even if I have a total knee replacement that is now going to be in the hospital for a couple of days. I think even for those patients, it'll be helpful because, you know, hospitalization in general can be a stressful time.
Hannah, this was great. This is Sue. I was wondering if you felt as if, you know, this was really looking with the therapist at them understanding trauma-informed care better to be able to utilize it with their clientele. However, do you think it changed the therapists in any way in terms of how they were handling their caseloads from an emotional perspective for themselves?
I think one thing I've really learned a lot from like the trauma informed care literature is in order to teach patients what we know, we have to be able to use these concepts for ourselves. So for example, like one of the interventions, like a sensory intervention, is using a 7-11 breath. So using really deep breaths in and out, 7 seconds in, 11 seconds out. In other trauma trainings that I've done, they always talk about how you need to be doing those things yourself before you can teach others. Otherwise, it will seem as inauthentic, if that kind of answers your question. So I just think the importance of self-reflection, personal attunement, which is also a common topic we talk about in trauma-informed care, kind of understanding your own thoughts and feelings on your own trauma experiences and your own ways that you deal with trauma, and then also being able to understand how that impacts your patients as well. So I think it definitely should inspire some therapists to kind of do their own self-reflection as well, if that makes sense.
Yeah, no, it does make sense, because I guess I was thinking about the impact of the pandemic, for example, especially on acute care therapists and, you know, the clientele that were being treated at that time, and how important some of this education really could have been with the very morally distressing issues that were occurring in acute care at that time.
I think COVID kind of really brought trauma-informed care to light, because it was very traumatic for many people, for not only the patients, but for the healthcare workers as well.
Yes, definitely. Thank you, Hannah.
You're welcome.
Any other questions? So this recording will be available to anyone who would like it later. There are further presentations this